Hello everybody, and thank you for joining in for today's discussion on microbial keratitis. I am Aravind Roy. I am a cornea faculty at Prasad Eye Institute in India. Microbial keratitis, and especially so in the developing world, continues to pose numerous challenges to the clinical ophthalmologist. This is not only a corneal emergency, but it is potentially sight-threatening and organ-threatening as well. And therefore, as ophthalmologists, irrespective of our subspecialty, we need to understand not only the nuances in managing microbial keratitis, but also we need to understand what would be a rational way in going forward in treating and saving the vision in these patients. So we'll start with a couple of cases just to give a perspective of how microbial keratitis presents in our part of the world. So this was a young patient, middle-aged in the third decade of life, and he sustained a minor trauma in his eye with hand, and this eye was having a blurred vision, and then there was some faint corneal edema and a convex hypopyon. This picture is very typical of probably a HSV stromal keratitis, which is immune mediated. Nevertheless, it's always important to scrape and look for any organisms should there be any organisms that are there. So at this visit, what we see was an epithelial defect and a small cellularity. And this patient eventually developed a more dense kind of a stromal edema in the central cornea. So we started this patient on steroids, and almost in a week later, he started worsening. So these are the telltale signs that perhaps underlying organism is very different from virus, and then we started scraping, and we found that this was a patient who had Acanthamoeba cysts. So this is something which is very common in our scenario, where it starts as a very early corneal edema and then starts to worsen the moment we give steroids. And this is very typical of Acanthamoeba keratitis. And these are the patients which will need a very long-term treatment of antiparasitic drugs. So this patient accordingly was started on PHMB and chlorhexidine with 3 times atropine sulfate eye drops. Eventually, the patient healed with a scar and was subsequently planned for a optical PK bar DALK. This was another patient where the patient presented with a epithelial defect. There was a central corneal cellularity. There was a melt in the cornea. The margins were irregular and ill-defined, and these were suggestive of fungus. And very truly, this patient, the hypopyon is very blurred, but there was a muddy, dirty kind of a hypopyon in the inferior chamber. So the patient showed septate filamentous fungus in the microbiology slides, and the patient was started on antifungals. It came out to be Acrimonium species. So then the patient was intermittently following up with us, and then at one visit, he presented with a bilateral loss of vision. What we saw was very shocking, and there was a almost complete corneal melt with a large paracentral corneal perforation. That was in the other eye. And the eye that we were treating, which is the left eye, this patient also had a perforation with a pseudocornea and a very dense and very unhealthy appearing cornea with a dense infiltrate, which was extending right up to the superior limbus. So the patient was planned for a corneal scraping, TABCL, AC deformation in the right eye, and the left eye therapeutic PK. So somebody is asking what is PHMB. PHMB is polyhexamethyl biguanide. This is a antiparasitic medication. So this medication is standard treatment for anti-Acanthamoeba. So this was the patient, the second patient, and then he was accordingly planned for a therapeutic penetrating keratoplasty in the left eye and a large corneal perforation in the right eye. So when we performed a microscopy, we found that there was gram-negative bacilli and the culture showed Pseudomonas. This was sensitive to only gentamicin but was resistant to other organisms, to other antibiotics. And the patient was started on fortified gentamicin in both eyes. And in the left eye, we started steroids, assuming that in the Pseudomonas infections and early steroid helps to control the inflammation. So this was the patient after the tissue adhesive bandage contact lens in his right eye, and in the left eye a penetrating keratoplasty had been done, but there was again a blood stained hypopyon in the left eye. So we continued to treat with the antibiotics in the left eye, but there was still a persistence of the hypopyon, and the anterior chamber always showed a possibility of a recurrence in such scenario. We always try to wait for the steroid, and accordingly we withdrew the steroid in this case because this patient was fungus to start with, and there could have been a possible secondary infection. There was also a large graft host mismatch with a graft override. So that could again have added to the poor health of the graft on the surface, and that could have led to the possible non-healing of the epithelium on the graft in the left eye. So this patient, again, a repeat scraping was performed, and we also thought that perhaps this is a time we should continue not only with the antibiotics but also continue to treat surgically this eye, and accordingly we plan to perform a therapeutic penetrating keratoplasty. This was the second or the repeat therapeutic penetrating keratoplasty in the left eye. So in this patient, again a therapeutic keratoplasty was done for his left eye, and the right eye we performed the TA again because the tissue adhesive had been lost and the BCL was also lost. So the right eye also, because of the persistent loss of the tissue adhesive, again a therapeutic PK was done in the right eye. The left eye, 2 times therapeutic PK has been done, and finally all the microbiology histopathology was also negative. So we could not ascertain whether it was the fungus to start with, was it the secondary infection with gram-negative bacilli, or something else that is contributing. So the purpose of discussing such cases is that in such a scenario, it is not only very difficult to salvage the eye, but also it involves an extensive workup in microbiology and try to understand what could be the challenges, what could be the possible organisms, and how can we effectively direct our therapy against such organisms. This is another case where the patient, a 52-year-old male who sustained injury with a foreign body, could be a vegetative matter, could be an insect, and then this eye developed a whitish plaque on the inferotemporal paracentral cornea. And there was ciliary congestion. The epithelial defect had a grayish plaque, and it was involving the mid to deep stroma of the cornea. When we scraped in the 40x in the potassium hydroxide, 10% potassium hydroxide wet mount, we found that there were septate, hyaline, and branching fungal filaments. And the culture showed Aspergillus niger, and we started this patient accordingly on natamycin and atropine, and also with ketoconazole 200 milligram tablets. Eventually, the epithelial defect started to reduce, but there was the plaque continued to persist, and it was much more defined, well defined, and there was also a continued melting of the corneal stroma. There were AC fibrinous membranes, and we debrided this plaque and continued the same medication. But sometimes debriding can also be counterproductive, though as a standard measure it has always been described that debridement is required to debulk the fungal load in the cornea. But sometimes debridement can expose the underlying stroma to the inflammatory cells which are present in the, or the inflammatory cytokines present in the precorneal tear film, and actually accelerate the corneal melting that can happen in the setting of microbial keratitis. So this patient was eventually requiring a therapeutic, he was planned for a therapeutic PK because of the continued melt. But considering that this was a small sized defect and there was some amount of pseudocornea and early descemetocele, we decided that let us try with a bandage contact lens and a tissue adhesive. And that was what was done. And eventually this patient resolved with this treatment. But had it not, then we would have definitely considered performing a therapeutic keratoplasty for this patient. So these cases illustrate that since many decades, the incidence of microbial keratitis in the developing countries such as India, Myanmar, Bhutan, Nepal is considerably high than, say, for example, the United States. And in a very early publication about 20-25 years ago, the projected rate of new ulcers that occur each year in India was pegged at somewhere between 840,000 new cases of microbial keratitis. So we are practically dealing with a very high load, and we need to understand the changing demographics of this condition and also change the approach to such a condition so that we are much well prepared in handling this entity. So just about a year ago, we were analyzing the outcomes of microbial keratitis during the COVID-19 pandemic related lockdown. And we found that during the lockdown, the primary examination with a local ophthalmologist was way more than it was seen before the lockdown. And the prior medications were also appropriate. There was much more severe keratitis that are presenting in a tertiary setup as compared to the type of cases which we used to see before the COVID-19 pandemic. So what it means is that if we compare it to another earlier publication from our institute, we found that about 20 years ago or 15 years ago, about 40% of the treatment that was done in the community was either an indiscriminate combination therapy compared to an appropriate antimicrobial therapy that is currently being prescribed. So what it means, meaning this study and our previous study, is that the level of awareness in the community is much better, which is a very welcome sign. Number two is that there is a lot of awareness amongst the patients and also among the prescribing ophthalmologists. So whatever can be treated in the community is treated well, is treated appropriately, and the tertiary care is a referral for those cases which do not resolve or those patients who continue to worsen with the local treatment. So this could be because of the better understanding, could be the better availability of drugs, because of better health seeking behavior. So always there has been a kind of a dynamism between the tertiary and the community about whether we should have an empirical approach where we give a broad spectrum antibiotic, or should we chase the bug and try to get the microbiology. What should we do? Because sometimes the cases are very typical. We understand the clinical picture better, and always we may not be able to perform a good scraping, primarily because of the lack of a microbiology service for ophthalmologists. So this was another paper which suggested that when the clinical picture is very obvious that whether we are dealing with a particular type of organism, should we do microbiology? Is there a role of microbiology? Well, definitely the conclusion was that it is important to understand that not two ulcers are alike. Many organisms may have a final common pathway of corneal melting, and in such cases it is important that we should understand what is the underlying organism and treat appropriately. So a management should definitely be based on a good laboratory workup. But the limitation obviously is that there is a need for a well-equipped laboratory, requirement for trained staff, cost and logistics. So this is a question of how PHMB is prepared. Well, these are not commercially available. So PHMB is prepared in the pharmacy or compounded in the pharmacy. And there are typical tertiary centers such as in Prasad in India, or a couple of other centers in India, which when they get a request, we compound that and send it to the concerned physician. So, as I was mentioning that most ophthalmologists cannot afford to or do not have access to microbiology, but nevertheless, it's important to understand microbiology and the leaps and bounds with which microbiology has progressed in handling ocular samples. And it's also important to understand that ocular samples are extremely small in the quantity, and they need to be handled with care. Unless that is not done, it's very easy to miss an organism. So some of the new advances that's happening in microbial keratitis, or what has been getting in vogue now, is the Vitek 2 compact system, which is an automated system for organism identification and also for checking the antimicrobial susceptibility. So essentially, it consists of a cassette with a compact workstation, and then there is an analysis that happens inside the set of cassettes, and a barcode is generated. The codes tell us the type of organism right up to the genus and species, and then based on that, the final output tells us that what is the organism, what kind of drugs this organism is sensitive to or resistant to, and how do we classify this organism. So this is a reagent card, which is one use for every strip that we use, and for every sample we use one card, and the card is read by the machine, and there is a normative database within the machine which classifies this into the type of organism that we might be dealing with over here. So there are a couple of more questions also that yes, microbial keratitis can be cured, and corneal scraping does not yield anything, then we should definitely repeat empirical treatment. There are principles of treating empirical treatment. There are methods in which we should perform empirical treatment. Typically, we should start with a broad spectrum antibiotic. Why should we start with antibiotics? This is because that most of the organisms that we are seeing in our part of the world, they are primarily bacterial and not fungal. And when we start treatment with empirical antibiotics, we cover them for a week, and then we start to assess whether there is a response. If there is no response, then we definitely should stop for 3 days and then re-scrape again. So I'll be covering again in my subsequent slides about the principles of management of microbial keratitis. So coming back to some microbiology again, then immunofluorescence assay is again very important. This is especially more important when we are performing a test for assessing whether there is a viral infection, meaning, for example, HSV, which is a very common cause of microbial keratitis or viral keratitis. And this is an antigen antibody reaction. There is a tagging with a fluorescent dye, and it has a good sensitivity and specificity. So IFA, when it is positive, it is usually suggestive of a HSV infection. PCR again is a very sensitive technique. It has a sensitivity of 100%, but it is not very specific, meaning that while it can very easily catch minute quantities of DNA, but it may not be able to definitely rule out a disease. So again, in this, the DNA is taken from the scraping samples, it is extracted, and then it is amplified, and in a gel electrophoresis system, the type of the amplified DNA is again subjected to the electrophoresis, and these bands have a particular pattern which helps us decipher the type of organisms, because that's where they are neutralized by the tagged antibodies over there. So when we compared the HSC1 in a recent study, and we found that when we combine IFA with PCR, or IFA, which is immunofluorescent assay, with gene sustaining, then the sensitivity and the specificity increases. So if we just have a PCR, while we can easily catch the DNA, but having an ancillary test in addition to that will help improve our diagnostic capability, meaning we can rule out the disease in a better way, meaning the specificity also increases. Then what has now evolved is the use of real-time PCR. So what it does is that it not only tells us that there is a presence of DNA, but it also tells us that how many copy numbers exist for these DNA. So this was a recent paper from our group which showed that if we have a type of say HSV infection. Now HSV is endemic to population, so anybody above 35 years of age would probably have HSV, but just having the DNA is not enough. Should we have a particular type of copy numbers or a particular load of copy numbers? So when we see very high copy numbers, then that means that there is an active replication of the virus, and this shows that a real-time PCR, which can actually tell us that whether the copy numbers are low or high, tells us that whether there is an active replication of viral particles or the viral DNA, suggestive of an active infection. Then what's next is the MALDI-TOF. This uses the mass spectroscopy, and that helps in identifying organisms. And next is the NGS, the next generation sequencing. So this is analysis of the ocular surface microbiome. This tells us what are the different types of the genus and species that are present on the surface, and it is a very sensitive test. It catches many organisms and the DNA that populate. The demerit of this is that there are many commensals on the ocular surface and not necessarily the pathologic bacteria or the fungi that may be there, but the NGS helps in sequencing and identify the entire microbiome or the microbiota of the ocular surface. It is important because there is a certain ratio of the commensal versus the pathogenic organisms, and when there is infection, then the ratio of the pathogenic organisms are much more compared to the commensals that normally populate the ocular surface. So these are some representative photographs of next generation sequencing performed from the ocular surface and the type of phylum, the classified, the unclassified fungi that may be there on the ocular surface. And they can also be represented as heat maps, where it tells us that what are the predominant types of genus that are there or species that are there in each sample that we analyze. So in addition, there are certain ancillary diagnostics that we can perform in microbial keratitis, and one such is the OCT, the anterior segment OCT. This is important to understand areas of necrosis, cystic spaces, cellularity, areas of stromal infiltration, and presence of any retrocorneal membranes or plaques. This can help us plan easily the depth of the infiltrate, and should we plan for a surgical intervention, then such as a kind of a deep lamellar keratectomy, or where there is impending perforation, then we can document it better with the ASOCT. So this is again another case where there was a foreign body and there is a cellularity of the tissues that has been there. And this is beautifully captured by the anterior segment OCT. And this optically clear area is actually the foreign body with the back shadowing. And there is a lot of stromal edema and cellularity in the corneal stroma. Then confocal has been in vogue, but confocal is primarily a research tool, and very few people have access to it actually, and also needs a fair amount of operator skill. And what it shows is that what it shows is that every organism will have a particular morphology. For example, what we see on the screen is the fungal filaments. So fungal filaments would typically be highly reflective, double-walled. They may have septae, and they are usually sized between 3 to 8 microns. They have irregular branching, but a very uniform width. So that helps us distinguish that a deep-seated fungal infection can be easily seen on the confocal, whereas just a scraping would definitely miss this organism. Similarly, Acanthamoeba cysts typically are highly reflective, double-walled, round particles, and they are within the epithelial corneal epithelium or the stroma. So what should be the protocol in our laboratory workup, and is it necessary? When should we do the empirical treatment? What should be our initial treatment if microbiology should be unavailable? So this is a very interesting and a very important document that is recommended by the WHO, and it was also recommended by a group of experts from Southeast Asia. And this document is freely available online, and I would urge all of you to go through this document to understand what can be treated at a primary level and what should be referred. So a basic workup that anybody can do even without access to microbiology is to perform a light microscopic examination with a 10% KOH on a simple slide and put a cover slip. This is a very specific test, meaning that it has a specificity of 92%. It very easily helps to rule out any fungal or Acanthamoeba infection. Second, if we see a very well circumscribed lesion, but this is involving the full thickness of the cornea, it doesn't appear to be very severe. It is paracentral, not involving the visual axis. It's unlikely that this infection will be fungal or Acanthamoeba. And if it is smear negative, even then one can start empirical treatment and start with broad spectrum antibiotics. So I would like to understand what are the types of empirical treatment that you use in your clinical practice. So the majority seem to use commercially available newer generation fluoroquinolones, as you can see on the screen. So yes, there are merits of doing that because they are easily available over the, and in many countries it's also available over the counter, especially in Southeast Asia. And there are, I would say, ease of administering to the patient, but they may not truly be broad spectrum because many of them do not have adequate gram negative coverage. And secondly, there is a risk of resistance as well. So probably what would be best is to use one of the combination therapy with, say, for example, cefazolin with cephaloxacin or cefazolin with gentamicin. So coming forth with the management scenario, why should we use a combination? Because it gives you the broadest possible coverage for the antimicrobial therapy. It provides coverage for gram positive, gram negative, and in case there is a possibility that somebody has missed in the smear, and until culture reports are available, or sometimes even culture may not be possible, we can still cover against a lot of microorganisms across the spectrum. Second, suppose the ulcer is appearing to be non-severe, but it has a very dry appearance. It has feathery, ill-defined margins. There is a plaque, and it's likely to be fungal. And on the smear, we also get fungus. Then the likelihood of this being a fungal keratitis is very high. Now, as I started a couple of slides ago, that if we perform a very simple light microscopy and with a 10% KOH wet mount, we find out whether we are dealing with Acanthamoeba or fungus. We can easily start on the community level treatment with antifungal drugs. Now, when we start the treatment with antifungal drugs and the patient also is not suffering from a very severe variety of ulcer, then there's a probability that we can still treat and heal this ulcer at the community level itself. And if it doesn't respond, if it continues to worsen, if the ulcer looks like fungal but the smear is negative, then this is a case where one should refer this patient to a tertiary eye care. So treatment with antifungal and anti-Acanthamoeba drugs must always be started only when the organisms have been adequately documented. So which are the guidelines for referral of patients to a tertiary center? Number one, all severe cases. What do you mean by severe cases? Severe cases are those where there is a pediatric keratitis. Number two, where there is a ulcer which is threatening to perforate the cornea, or a ulcer which is approaching the corneal limbus. So, or where there is a possibility of an associated comorbidity such as an endophthalmitis. So in all of those scenarios where there is a probability that there is a need for a keratoplasty or a pediatric case, or there is involvement of the ocular structures adjacent to the cornea. In those cases, definitely one should consider referral to a tertiary service. Then, is there a role of fluoroquinolones, corticosteroids, voriconazole? Should we do monotherapy versus combination therapy? This is the question that we had asked on the poll. So we noted that fortified antibiotics typically are not commercially available. There is a limited shelf life. There are issues in the storing these drugs. The pH may change. And when we use fortified antibiotics, they usually cause surface toxicity. So fluoroquinolones are easily available, easily prescribed. They do not need to be stored under very specific conditions. And they can be very easily used by the patient. And they are commercial formulations. And they are comparatively less toxic. But there are issues. So when we looked at the Backer study, we found that gradually, say over the last decade or 2 decades, continuously there has been the problem of drug resistance, and more isolates tend to be resistant to fluoroquinolones. So what was susceptible 5 years ago is no longer susceptible. So not only a judicious use is required, but perhaps it's important to shift to a altogether different class of antibiotics. So if we are looking at an ulcer which is smaller, less than say 2 millimeter, non-severe, and probably involving the superficial corneal stroma, then it might be useful to start with a fluoroquinolone or give a fortified cephalosporin with an aminoglycoside. And how long should we treat? Typically, we should treat as long as the ulcer has not completely healed. And we should not taper an antibiotic, and rather when there is a scarring, then we should stop abruptly. So tapering is never done in prescribing antibiotics. Is there a role of corticosteroids? Well, there has been studies which have shown that corticosteroids reduce the inflammation and the scarring, but sometimes they may accentuate the melt and the perforation and a secondary infection as well. So there have been numerous studies, good quality evidence, which has shown that there is a very little impact of using antibiotics in conjunction with steroids with antibiotics in treating microbial keratitis. So this role is very limited, and the treatment is at best avoided in corneal ulcers. Treatment of co-treatment with corticosteroids is probably avoided. This was a patient who was a young male of 3 weeks history. And as you can see that there's a very ill-defined, dry, feathery appearing lesion on the cornea. And when we scraped, we found filamentous branch, thin filamentous fungi. And the calcofluor white in fluorescein microscopy, it again showed the same patterns. So this patient required antifungals. Now, antifungals come with different classes of drugs, and there is a lot of change in the prescribing patterns that has been happening. And there are many anecdotal reports that apart from polyenes, the imidazoles, triazoles, and the fluorinated pyrimidines are also extremely helpful in managing fungal keratitis. So should we shift to the azoles or continue with the polyenes, which is the natamycin? So, and is there a role for the newer drugs such as voriconazole? So as the MUT trial showed, the mycotic ulcer treatment trial, which was published almost a decade ago, or a little more than a decade ago, we found that still natamycin is the best possible opportunity that we have, the best possible drug that we have in treatment of fungal keratitis. Voriconazole is important. Voriconazole has been found to be effective in aspergillus, but then based on the overall clinical spectrum, it has been found that the natamycin is a better drug, and it helps to treat the filamentous fungi in a better way compared to, say, voriconazole. So in addition, there has been a lot of interest in the use of intrastromal injections. So the procedure is very simple to perform. In those deep-seated mycotic ulcers, it's important to insert the needle. This is a 29 gauge needle, which is inserted into the mid-level of the stroma. The drug is typically divided into 5 doses, and it is injected into the mid-stroma so that we create an area of whitening around the area of the infiltrate. And I will be using this drug 360 degrees all across the area of cellularity and infiltrate, and this helps to create a barrage of the drug around the lesion. Typically, 2 injections are given 72 hours apart, and we try not to give more than that. The dose is 50 micrograms per ml, and this has to be fractionated and created. So the other thing that we look for is a collagen cross-linking in the setting of microbial keratitis. But again, collagen cross-linking has been designed for arresting progression in keratoconus and not typically for the treatment of microbial keratitis. But nevertheless, it has found an interesting application in intractable ulcers. But there is no definitive protocol for replicating collagen cross-linking, and the degree of melting might be more. So the standard protocol that is used for collagen cross-linking may not be recommended for microbial keratitis. And a recent study by Prajna et al. Also showed that there is no improvement in microbiological cure. There is no improvement in infiltrate or scar size, and there was no increase in the percentage of epithelialization and no difference in adverse events, and the need for therapeutic PK in collagen cross-linked eyes for fungal keratitis. In bacterial keratitis, it is still used, but again, it is very variable. And while it can be used for small, tiny peripheral ulcers, but for large ulcers, it may have very little implications. What also is being increasingly studied is the use of photodynamic treatment. So PDT is something that is interesting because photodynamic treatment helps in creating activated reactive oxygen species, which has a killing power, and it helps to kill the bugs and help in an ancillary treatment of microbial keratitis. So in this, Rose Bengal has been tried in different combinations, and it has been found to be much more effective in killing the bugs compared to a control. So this was a pilot study, and it was greeted with a lot of enthusiasm about treatment of photodynamic therapy, Rose Bengal, in patients who have had Acanthamoeba. But again, these are also plagued by the same questions of drug penetration, time-consuming therapy, how many times should we use, what should be our standard application, and what should be the results. So in summary, it is important to be familiar with the science of managing corneal ulcers, the art of making a diagnosis, definitely have a good microbiology support, refer to the guidelines, and understand that the roles of fluoroquinolones, corticosteroids, newer antifungals, there are some advantages and some limitations, and one should make decisions based on these limitations. So thank you so much for a patient hearing. We can take a few questions before we end the session. So there are some questions in the chat box. I'm going to start one after the other. One is that, is there a role of biofilm? Biofilm is extremely important because that has been found to be one of the reasons of non-response to medications. And biofilm forming bacteria have been extremely resistant or tenacious to treatment, and that is one mechanism by which bacteria develop resistance. Then in the case of small perforation using glue plus BCL. So glue plus BCL is easy to do, and it doesn't really require any surgical expertise. It can be a very simple way of intervening without performing a tectonic graft. But the limitation is that we can only perform this procedure up to a 2 millimeter perforation and not beyond that. If it is 2 to 3, we may need some other procedures like a Tenon's patch graft, or tectonic corneal graft definitely is the go-to method if there is a large perforation. Corneal ulcers are caused by microorganisms. This is secondary to an abrasion of the cornea, which could be because of a trauma. Usually in the developing world, it is trauma during agricultural work, and agricultural laborers, they may get, or workers, they may get injured due to some occupational hazard, and then that may get secondarily infected, and it could be both bacteria, could be fungi, or any other parasite like Acanthamoeba. Fluoroquinolones typically are started in a loading dose, meaning hourly for the first 48 hours, following which they are given in a maintenance dose of 8 times a day until resolution, following which they are abruptly stopped. So these drugs are never tapered 4 times a day. It is given 4 times a day only in the setting of cataract surgery, where we give these antibiotics as a prophylactic measure. There is no infection here. We give the drugs to prevent any possible infection. So yeah, frequency of topical, we have answered this. Okay, next, are there specific drugs for the use of intrastromal injections? So typically we give intrastromal injections for fungal ulcers, and both voriconazole, amphotericin B, and in the sol form natamycin can be given. Antibiotics are typically not preferred because the pharmacokinetics of antibiotics are good, penetration is very good, and usually the antibiotics reach the aqueous well. So there is very less requirement of giving antibiotics as intrastromal injections. Metaherpetic keratitis is more like it is because of the excessive use of antivirals. So there one needs to stop the therapy and allow the healing to occur. So steroids, again, I would not use in metaherpetic, or rather I will use lubricants and observe this case. Then can OCT be the first line of, yes, definitely it can be the first line investigations. But what we also need to understand that we may need to find out the underlying organism and start treatment accordingly. A major cause of microbial keratitis is a abrasion which gets secondarily contaminated, because microorganisms are ubiquitous. They are available everywhere, and any breach in the continuity of the epithelium, one can have an infection, secondary infection. Photocoagulation, very poor, as the Clare studies show that there is very limited role of collagen cross-linking. So all the photodynamic treatments are being investigated. PDT is still found to have some promise for fungal keratitis, but collagen cross-linking definitely is counter effective. There is a role of doxycycline, yes, because theoretically it reduces the melt of the corneal stroma, but again it is subjective. Many experts use it, many do not. Primary line of treatment of microbial keratitis is to use these drugs primarily as a combination therapy of fluoroquinolone with a cephalosporin, so that we get maximum coverage for gram positive and gram negative organisms. Natamycin is a good drug. I understand that probably natasan is natamycin. So natamycin is a very good molecule, and it is the first line treatment for many types of filamentous fungus. That includes both aspergillus and also fusarium. So definitely that can be a good choice of drug for filamentous fungus. The guideline on WHO, this is, you can Google this by WHO guideline for referral of antibiotics. Sorry, not referral of microbial keratitis. So this is Southeast Asia, WHO guideline, microbial keratitis can be some of the keywords. It is freely available online. You may select and download it at your convenience. How to deal with adenoviral conjunctivitis? Probably adenoviral conjunctivitis needs only supportive treatment with lubricant eye drops. So if there is a bacterial keratitis, which is again contaminated with conjunctivitis, just consider adding lubricants, topical lubricants. Autologous serum I have never used in the setting of severe microbial keratitis. I feel this is more useful in dry eyes, so not sure about that. For bacterial, we use the combination antifungal, the broad spectrum therapy, which is cephalosporin and fluoroquinolone. And for fungal, our first line treatment is natamycin. Intrastromal injection dose is 50 microgram per ml, and we give about 0.1 to 0.2 ml in 5 divided doses. And typically we use voriconazole, but one can also use natamycin in sol form and amphotericin B also. Crystalline keratopathy, again that's a bacteria, so we'll again use a antibiotic for crystalline keratopathy. Hypopion could be infectious. In fungal keratitis, they may yield some fungal filaments. Bacterial, it could be only inflammatory. So paracentesis routinely is not required, but one can do a AC wash. Is there a role for subconjunctival antifungal? We have never tried that. And also antifungal drugs are very toxic. So giving subconjunctivally may lead to local necrosis and a lot of pain. Antifungal drugs from capsules, I have no experience. Is natamycin a eye drop? If it is, yes, but I have no experience of antifungal drops. Compounding antifungal drops. Then a combination of gentamicin with moxifloxacin, yes, certainly you can do that. Then do we encounter keratitis from Pasteurella? I'm not sure. I am not sure we see this organism, but probably you can consult with the microbiology laboratory as to the sensitivity profile for this organism and accordingly treat it. Stromal injections are contraindicated when there is a corneal melt, impending perforation, or an actual perforation and a desmetocele. In such cases, definitely we avoid giving stromal injections because that may lead to perforation of the cornea. In pregnant women, again, very difficult. One should use either erythromycin or probably those which are having least systemic absorption so that there is no inadvertent toxicity in the growing fetus. Sensitivity and specificity of corneal scrapings are very different depending upon how the study is designed. For example, in bacterial keratitis, the sensitivity will be somewhere in 80–85% and specificity will be somewhere between 68 to 72%. But it all depends on the number of samples we are taking for that study and how many positives we are getting. But the broad rule of thumb is sensitivity and specificity are in the ranges of 60 to 70% and 80 to 90%. Contact lens can definitely cause keratitis. In such cases, also in addition to microbiology, culture the solution, culture the lens, and find out the causative organisms. It can be caused by Pseudomonas, it can be caused by fungi, and one has to treat accordingly. Atropine in drops is better. Ointment is given typically for children because if they cry, then the ointment will stay in the eye, but the drops will get washed out. Subconjunctival injection, I do not use them. They cause a lot of pain to the patients. So better is to use a topical preparation. And if you feel that the patient is non-compliant, then in those cases, we can admit the patient and observe for a couple of days. Vitamin C, again, it helps in collagen, preventing collagen breakdown. common risk factor is typically trauma, diabetes, maybe corticosteroid use indiscriminately. All of these are risk factors. Intrastromal injections, again, a lot of information is available on the internet, but to simplify it, typically this is used in mid to deep stromal fungal keratitis, intrastromal injections. Voriconazole can be given. 50 microgram per ml is the recommended dose, and it is given in 5 divided doses to form a barrage. So you can refer to our publications on the web, and also to the video that I showed. I think this video will also be present on the CyberSite library. You could consider revisiting it should you need to refer to it. Fortified, we don't make fortified antifungals, so I'm not sure how to make that, but voriconazole also comes as an injection. So if we can have a pharmacy which can compound it for us, we can make drops from there. Steroids, I typically do not use steroids in the management of microbial keratitis. In severe keratitis, we try to refer it to a cornea service. And in those cases, we may need to perform emergency corneal transplants. So it's important to send it immediately. If we cannot do, or we do not have the availability of a tertiary service, then try using a tissue adhesive. If nothing is available and you are in a community where there is no cornea service available, probably try doing a Gunderson's flap or a conjunctival flap. Probably that's the last resort somebody can do, because at least it will help heal the ulcer and reduce the pain. A new patient of MK has imminent perforation. We should do the scraping in the operation theater and keep ready tissue adhesives or a cornea for transplant in case there's a large perforation. But yes, scraping, we very commonly do this procedure, but we do it in the operating room. Role of Panthigel, I'm not sure about this. Antioxidants, yes, they are supplements, can be used. Can we give intrastromal steroids? No, I have never tried. They are usually given in ocular allergy, but not in the setting of ulcers. Hypopeon has very little role. Aspirating it immediately collects within the next 6 hours to 12 hours. So its role is very limited. Sometimes fungal ulcers may have fungus in the hypopeon also, especially deep-seated ulcers. In such cases, that hypopeon may be sent for a microbiology analysis, and this can help us give the diagnosis. NSAIDs are required for treatment of the ulcer, the pain that is associated with MK. In severe fungal keratitis, if there is involvement of the sclera, yes, we also do evisceration. If antifungals are available, then we can prepare them from the systemic voriconazole, and we can add a oral antifungal. Steroids in SPK, probably not required. One can give, but SPK is like superficial punctate keratitis. It can occur due to a variety of causes. So it's kind of a generic diagnosis. So unless we do not know the cause, giving a steroid can be tricky. A cost of penetrating keratoplasty, probably not much in any society, but what is important is the follow-up of the patient and the compliance to steroids after the keratoplasty. So if a patient is from very remote, far off, not able to come, then keratoplasty may not be very helpful in such a setting. NSAIDs causing melt, I'm not sure about that. Usually it does not, but I'm not sure. Would you mean a topical NSAID? Probably, but systemic NSAIDs, no. Okay, then, so I think we have covered more than 50 questions, and that's amazing. All of you have been a very, very interactive audience. So thank you.